Good morning, everyone. I am Linda, and I'm currently based at the University of California, San Francisco. I'm excited to share some insights about career in pharmacometrics from an academic perspective. I've organized my presentation into the following parts. First, I will talk about what motivates people to pursue pharmacometrics career in academia. I'll then walk you through the different routes you can take to get there. Third, I will outline the main career tracks available for pharmacometricians in academia. I'll then share a bit of my own story and how I found my way into this path. I'll then talk about key skills that have shaped my journey and helped me along the way. And I will finally close with some reflections on opportunities and challenges facing academic careers today. There are many reasons why an academic career can be appealing, but let me just highlight just for today. First, in academia, you have the freedom to decide the direction of your research. You are not really limited by the market priorities or maybe deadlines, but instead you get to pursue the questions that really keeps you awake at night. Secondly, academia is a place of continuous learning, and whether you're learning through your own research or collaborations with your colleague, you're constantly challenged and inspired. Third, there are opportunities to train and mentor the next generation of pharmacometricians. I find this deeply rewarding as you get to pass on your passion, and in the process, you learn and grow alongside your students. And finally, academic research often tackles problems that industry might not find commercially attractive, but are really important for patient care. For example, think of research in rare diseases, or maybe optimizing therapy in resource-limited settings. These are questions that truly make a difference in public health. So the question is, how do you actually get into academia as a pharmacometrician? So the traditional pathway is pretty familiar, and it starts by completing a PhD, then one moves into a postdoctoral fellowship and then transition into a faculty role. But this is not the only way. More and more people are entering through alternative routes, for example, starting in industry and then gaining valuable experience there and then moving into academia either through joint appointments or collaborations. So yes, the PhD postdoc faculty track is really common, but it's not the only story. So once you enter academia, your career can take shape in a few different tracks. I like to think of this as different hats that we wear as academics. The first hat is teaching and mentoring. Here you get involved in designing courses, guiding students, and also inspiring the next generation of scientists. The second hat is research, and this can take many forms. A few examples are like developing new methodologies, applying pharmacometrics tools to the real-world challenges, translating science into policy and practice, among other things that you can do as a researcher in academia. And lastly, there is this third hat called service and leadership. And this could lead to, could mean you leading professional societies, for example, ASCPT and PAGE. It can also mean you are involved in reviewing manuscripts. You can also lead institutional research consortium or even direct graduate programs. This is just not limited to just what I've just listed. There are other opportunities under service and leadership that you can take as academician doing pharmacometrics. In reality, most of us wear all these three hats. The difference is in proportions depending on your role and also your institution. Now, let me walk you through my career journey, which is just one example of how someone can find their way into the pharmacometrics in academia. One, I began with an undergraduate degree in statistics at the University of Nairobi. then a master's in biometry at the same institution. So by the time I was moving to Stockholm University for my PhD in biostatistics, I knew I wanted to work at the intersection of data and patient outcomes. But the real turning point came through a series of short courses and fellowships as far as pharmacometrics is concerned. And these experiences I gained, especially during the APT program, opened my eyes to this field of pharmacometrics. Networking played a big role too. And through professional connections, I was offered an opportunity to do a postdoctoral position at UCSF, that is in 2023. That was another major pivot for me. And today, at the same institution, I'm focusing on translational research in the TB space. Alongside, I also get opportunity to teach and mentor graduate students at the School of Pharmacy and also collaborate widely across disciplines. Something really quite interesting about my journey is, especially during my graduate studies, I also got opportunity to work. And the combination of formal education and also practical aspects of this really shaped my journey to where I am today. I'd also like to highlight some skill sets that are essential for pharmacometrician, whether you are in academia or industry, for example. And first is quantitative and technical skills. I believe these are non-negotiables in our fields. And my background in statistics gave me a solid foundation, but I've had to continuously build my programming skills, which I believe is critical for data analysis and modeling. Secondly, the principles of pharmacology. So it's really just not enough to build models. One needs to really understand the biology and the clinical context to make sure that the models that you are building are meaningful also for patients. And third, soft skills. As we all know, pharmacometrics is highly collaborative. You find yourself working with clinicians, regulatory experts, and also drug developers. So communication skill is really key, whether you are writing grants, presenting at a conference like we are doing today, and also explaining models to collaborators who have no quantitative background as yourself. And lastly, leadership also become increasingly important as you move along the ladder in the academic position, because at one point you'll be required to lead a project and also mentor students. And from my perspective, here are some of the opportunities I see for building academic careers in pharmacometrics, especially in the African context. First, I believe universities across Africa are expanding rapidly with new programs being developed. And new programs, for example, in pharmacometrics means new faculty positions and leadership roles that really didn't exist like a decade ago. Secondly, the field of pharmacometrics in Africa is less saturated compared to Europe and America. And this gives room for faster career progression, opportunities to lead programs early in your career, and even shape how pharmacometrics develops on the African continent. And third, Africa brings a unique research opportunities. This is because our populations, I believe, are underrepresented in pharmacometric studies, yet we have very rich genetic diversity combined with unique disease burdens. This creates a chance to generate data that can lead to better and more tailored therapies. Finally, academic pharmacometrics career are about more than just research. You are also building sustainable capacity through training the next generation and creating a long-term expertise. So let's take a moment to talk about some of the practical realities of academic life as pharmacometrician. One, securing funding is competitive. But to look on the brighter side of things, it's also a skill that you can develop and you can grow. So with persistence, good grant writing, and strong collaboration, opportunities really do open up. Secondly, academic academia gives you flexibility and intellectual freedom, but it can also spill into your personal life. So research doesn't always fit into an 8 to 5 schedule. Grants, deadlines do not respect holidays. So learning to set boundaries and manage your time is really important. And also, it's really true that salaries in academia is lower than that in industry. And also, success is often measured by publications you produce, the citations your work receives, and also the grants you secure. So the pressure to publish or perish is real, but it's also an opportunity. It gives you a chance to build your reputation, demonstrate your expertise, and ultimately shape the direction of your own research. I share this not to really discourage anyone, but to help you prepare or also just create awareness. And with the right strategies, these challenges can become opportunity for growth and to make great impact. And if you're drawn to the intellectual challenges, if you are passionate about mentoring others, if you're motivated by the potential to make a lasting impact on human health, then academic pharmacometrics can be a rewarding career choice. And to end, I really want to acknowledge the many individuals and institutions that have supported me throughout my journey. While I have been blessed with support from numerous people, I cannot mention everyone by name. I am deeply grateful for their contributions. Thank you.
Thank you.
And it's to you now, Babatunde.
Okay, thank you. It's been an exciting and inspiring session, and all we agree with me that we are it's full of insights. But I've seen agitation for questions and answers. But one thing is intentional that this session there not be any question and answer session. This session is to provoke us to look for ideas, look at potentials, and look at things to discuss during the panel's discussion. So I want you to note both the online and in-person participants to note some of the insights, some of the potentials, some of the challenges that we have derived from this session. And when we are in the panel of this discussion, then we can raise them and discuss them together. So in closing this session, I want to appreciate our speakers, Professor Katrina Watts. Thank you so much for that inspiring session. Thanks Dr. Steve Ken and Ida, Eliford, and Linda for those inspiring presentation. So as we move on now to the next session, I thank everybody, the in-person and the online participant. Thank you.
And we now move into the second session, which is bioavailability and bioequivalence. And while the chairpersons in the room here come up on board, we have another set of video messages that we'd like to share with you.
Je me présente, Marie Rasgalarou, professeure de pharmacologie à la faculté de pharmacie de Monastir en Tunisie. Avec un ensemble de collègues et d'experts en pharmacométrie, nous nous sommes engagés à promouvoir la pharmacométrie en mettant en place le Tunisian Chapter, un chapitre affilié à PMXAC2025 qui a la spécificité d'être en langue française. Ce chapitre, comme tous les chapitres de PMXAC2025, coordonne un ensemble d'événements, de formations, d'ateliers, de webinars en relation avec la pharmacométrie, ce qui va permettre aux étudiants et aux professionnels de la santé francophones d'accéder à une formation de haut niveau en pharmacométrie. Aujourd'hui, la majorité des formations disponibles se font en anglais, ce qui limite l'accès aux francophones. Notre programme vise ainsi à rétablir une équité d'accès à la formation et à créer des opportunités pour tous. La pharmacométrie, rappelons-le, est une discipline scientifique qui applique des modèles mathématiques pour analyser et interpréter des données issues de la pharmacologie, de l'évolution des maladies et des réponses des patients. Elle constitue ainsi un outil essentiel aussi bien à l'hôpital qu'en industrie. En Afrique, les pharmacométriciens formés demeurent rares. Plusieurs raisons expliquent cela. Absence d'un écosystème de développement de pharmaceutique, étant donné que la majorité des multinationales sont basées en Nord-Afrique et par conséquent il y a un manque d'opportunités d'emploi. À l'hôpital, la pharmacologie clinique est peu développée en raison d'un manque de ressources humaines et d'équipements nécessaires pour le développement de cette discipline. C'est dans cet esprit que nous portons aujourd'hui le projet du Tunisien Chapter. Nous sommes convaincus que l'Afrique peut et doit renforcer ses compétences en pharmacométrie afin de contribuer à l'amélioration de la santé publique. Grâce aux avancées des technologies de communication, à l'émergence de consortiums et aux réseaux collaboratifs, saisir des opportunités de travail depuis l'Afrique n'est plus un rêve inaccessible. C'est ainsi que de nouvelles perspectives s'ouvrent aux chercheurs professionnels de santé et acteurs de développement pharmaceutique sur le continent. L'expertise qui sera acquise permettra ainsi de retenir la force vive africaine sur le continent pour qu'elle contribue directement au développement local, régional et continental. Toutes ces raisons nous ont poussés à promouvoir l'enseignement de cette discipline afin de contribuer à la formation de nouvelles générations de talents capables de porter l'Afrique au premier plan de l'innovation pharmaceutique mondiale. Suivez-nous, le lancement du programme, le recrutement des candidats seront ouverts début octobre sur la page PMX Africa. Et n'hésitez pas à contacter Dr Nojtiba, chef de projet, pour toute information complémentaire. Et là, il ne me reste plus qu'à vous souhaiter de bien profiter des travaux de la conférence et bonne chance.
Hi, everyone, and welcome back to our second session. Before I hand you over to the chairs, I hope you guys had a great cup of coffee and you're all energized for the session that's coming up. It's going to be extremely enlightening. But before that, let's just touch on some housekeeping rules very quickly. So maybe more to our virtual delegates first. I encourage you to get the energy going in the room, and please post your comments into the normal chat, but all Q&A for the speakers, for the specific questions related to our presentations, please use the Q&A button on Zoom. And some of these questions, we could also then bundle them up for our final panel discussion session. And feel free to use the chat socially. Also, please wait for a microphone before asking your questions. This is particularly to the delegates in the room, so we can all hear you nice and loudly. And this ensures that we hear on the other side of the screen actually hears you as well. All right, and then to our virtual delegates, please remember that for each session, you would be required to log on. So if you feel like you're automatically kicked out of the room, please note that you would be back probably in the lobby again, and you would have to join the next session. Right, and then two very important things. Firstly would be the social media. Please put up your experiences, share the activities of the day, get the word out there. We'd love to hear from you as well. And these are the following links you could use on social media. In addition to this, please remember the Delegates' Choice Awards as well. So please do take the time to visit the posters, network, socialize, interact, create new collaborations, and also use our social media wisely. Over to you, Phumla and Natalie.
Welcome to session 2. In this session, experts will discuss how bioavailability and bioequivalence studies ensure the safety and effectiveness of generic medicines, which is a major priority in Africa, where generics account for over 95% of all medicines. Although typically based on straightforward methods like non-compartmental analysis, these studies are essential. So presentations will highlight how advances in AI, including large language models, can boost speed, accuracy, efficiency of bioequivalence and bioavailability evaluations. So our first speaker is Bill Denney. He is the executive director and the founder of Human Predictions LLC. He has about 20 years of expertise in mathematical modeling and drug development. Previously, he served as a director of clinical pharmacology at Pfizer, where he led clinical trial design and innovative modeling approaches. He also pioneered model-based meta-analysis tools to enhance transparency and optimize clinical trial design and outcomes. Over to you, Bill.
Thank you very much, and thank you for the opportunity to present today. Most important for the delegates in the room, there are stickers coming around. Very important for any software talk that you have your stickers ready. So yes, today I'm going to be giving a little bit of a different flavor of talk, where I'm going to talk about how I do bioequivalence evaluations within open source packages. Specifically, as the primary developer of PKNCA, that's going to be the main focus. But the idea here is to give some hints on ways that the evaluations can be done, and the fact that all of the tools available are readily available for everyone to be able to see and use. So why do we want to use open source software? And the core ideas for me are usability, interoperability, and options. I can readily use any open source tool in any way that I want. I don't need to have any I don't need to have limitations on, I can only use this one piece of software in the ecosystem of the software it's used. I don't have to transition between systems. One of the hardest parts when I was first starting out was I would need to take a data set and maybe I would need to convert it into Phoenix, or actually at the time it was WinNonLin was its own product. And then take that WinNonLin data and then export it and then re-import it into R and change all of my different column names. Actually, it was S+, but leaking together here. And the general idea that there were heavy challenges of getting between step 1 and step 2 and step 3. And with open source tools, you can readily connect all of the parts together. You don't have to spend a huge amount of time moving from tool 1 to tool 2 to tool 3. My current workflows, I do everything in one step. There is, from the original data management, the exploratory visualization, the non-compartmental analysis, the modeling and the reporting. I code it all together, hit go, and I know that my results are consistent. And I cannot do that with other tools because of the need to jump between tools. Or if I can, it takes Herculean effort to do so. The other thing that I really like is clarity. How does the system work? I can dive as deep as I want and know every single detail about how the system works. As I do a lot of programming myself, I can help find bugs. There's a joke between a lot of my friends that I tend to be the universal edge case. I will find a bug in your software no matter how well tested it is. If it's been on the market for 20 years, I'll find a bug. If it's been on the market for 20 minutes, I'll find a bug. It's just all the time. And that's, just to be really clear, bugs are not something that happens in one type of software or the other. Bugs happen in all software. I wish I could say PKNCA was bug-free. It's not, but neither is any other tool that's out there. And it's really important to realize that when people talk about gold standard software or gold standard methods, what they usually mean is, I've done that for 10 years, so I feel comfortable with it. Not, it's actually the right answer. And there are plenty of ways where any piece of software can have issues found with it. and I don't want to throw any one particular software under the bus, but tell me your favorite software and I can tell you a current problem with it, I'm almost certain. And I put cost intentionally last. Cost is important for everyone, but it's not the primary reason I use open source. I use open source because it works better. It works for every need that we have there, and in many cases, I can do what I need to do more easily, faster, and often with the same or even higher quality than I can with closed source products. And all of these other things mean that as I'm working with the tools that the open source tools that I use and developing PKNCA, the reason I do all of this and the reason I use these tools is to make sure that we can really that things are easier when I'm writing when I'm using PKNCA to do my non-compartmental analysis. I can do it in about a third the time that I can with any other tool. My time. And my time and your time are the most important time. I can run it on a computer and it takes the same amount of computer time, but it takes less of our time, so we get to think about other things. And what software we use varies. These are the tools that I use that are relevant to bioequivalence evaluations, and there's so many tools available. This is a focus on R-based packages, but there's Python, there's Perl, and there are other types of tools available. I focus on R because that's the primary ecosystem that I work in. And these tools really enable every step of the workflow from top to bottom. And with that, you can, like I said, do everything you need to across the spectrum. And the other thing is people are available to help. You can really engage with the people who are developing it. For PKNCA, it's on GitHub, and put a message in the discussion section. If you have a problem, put it in the issues section, and it'll get resolved by me or someone else who uses it. And with that, what is the typical workflow? So I'm going to kind of go through a little bit more detail on some of these parts, and later on, I'm happy to go through other components of why some of the parts work as well as they do, and some of the challenges. So typically my day starts by opening up R. That's probably a consistent thing for all of you. And so I don't think I need to speak all that much longer about R and RStudio. If that is new to you, let's have a chat, but I'll step a little bit farther down. Then I load and clean the data. And if I have standard data, so I'm working with a non-clinical study or an academic group, generally if I'm working with anything that is not a clinical trial run by a large pharmaceutical or biotech company, and even for those, I will be using Tidyverse, which helps you load the data, helps you organize the data, helps you move the data around and put it in the format that you need. And if you ever receive data that you don't have to do any data management on, please tell me. I want to work with whoever you're working with, because that doesn't happen in my experience. If you are working with data that's in the CDISC formats, SDTM and ATOM, then there's a large effort that is actively developed within a collaboration between academia and industry called Pharmaverse, where it really helps you build the data you need to build. It helps you find, it helps you organize the data. It helps you put things together in a consistent and way that follows the international standards. And that is not to be underestimated, because for those who came to the Digital Health Africa conference in the past couple of days, there was a large discussion about standards. Standards are always harder to work with, but if it's ever not a one-off, it's almost always the better thing to do, because if I need to hand my project off to you or you or you, we don't have to spend hours or days or weeks talking about what I'm handing to you, because you have a very real chance of already knowing how to use it. And so these parts are built by many and built by experts so that you don't have to re-implement them yourselves, which is key. One thing I should say in general, as you are coding more and learning how to code more, do your best to stand on the shoulders of what others have done. And that's something that open source really does enable dramatically well, that you don't have to re-implement how do I load an STTM data set and how do I create an Atom data set from my STTM. Other people have done it, they've made it open source, and you can use that to take the next step yourself. From there, will surprise no one in this room that my next step when I'm doing non-compartmental analysis is to use PKNCA. And the reason for that, I'm going to go into more detail in the next few slides, but it's because for me at least, it works better. It can do all of the calculations that I need it to do, and it can do it effectively, it can do it quickly, and it can do it with fewer steps than other tools may require. For bioequivalence calculations, I've actually had several discussions in the past few days about, how do I do bioequivalence with PKNCA? And the number of discussions I've had on that in the past couple of days moved it up the priority list to bring it into PKNCA. But my current method is to use the replicate BE package, which is made by Helmut Schultz, who is possibly the world's best expert in bioequivalence. He's written so much on the topic, and he's cross-validated replicate BE with many different other tools. It really works well, and it will work in any design, any analysis that you might need. I also know that there's some APT fellow action on helping to understand how replicate BE and some of the methods that it uses cross-validate with other methods and other software to really understand when you're getting the same result, when there might be a difference, because there are, like I said a moment ago, any software may have bugs, but if you don't know about them, you can't handle them. In some cases, when I'm doing model-based bioequivalence, which is a more recent development to understand how bioequivalence may work by really using a population PK model to just look at, okay, I'm giving a new oral formulation, and so the absorption rate and the relative bioavailability may change, but the clearance didn't change. It's still the same molecule. And so you can use model-based bioequivalence to evaluate that, and there's an R package for that as well. And then if I'm taking the next step into pharmacometric modeling, I'm also one of the on the development team of InnoMixer2, which really, which can do literally anything that any other package can do in terms of, so everything that non-mem can do, everything that Monolix can do, and can really bring everything together in a strong population PK framework. And a whole lot more. Today's topic is not intentionally on InnoMixer, but there was the course on Monday, and happy to have questions after the fact about it. And then finally, for reporting, one of the consistent themes has been how do you communicate with others, and a very important part of that is doing it reproducibly. Really making sure that when you're communicating, you know that your results are accurate, you know that your results are traceable. And for me, this entire process is one script. I didn't mention it, but I also use a different package that adds another layer of complexity, but it makes sure that everything is self-contained, which is called the targets package, which really brings it all together so that you make sure that everything you're doing is consistent from data to report. A little bit of history about PKNCA. How did it get here, and why does it exist? The prehistory is that before being a consultant, I worked at Pfizer, and one of the early tasks that I worked on was helping with dose escalation meetings for first-in-human studies. For people who have not participated in a first-in-human study, it is a high-intensity environment where there were days where literally the data would be refreshed in the database at midnight. We had to review it by 10 a.m. so that a decision could be made by noon, so that patients could be dosed the next day with the next higher dose level. That's not all that much time to do all of your analysis and make sure that everything is taken into account. And so the precursor to PKNCA was built with that in mind, where we could take in the clinical data set, we could take in the PK data, mesh them together, and come and flow through to have the non-compartmental analysis come out, and many other parts that went into it to make sure that we knew, were we able to escalate to the next dose? What was our exposure, our AUC and Cmax, to make sure that we were within safe limits as we escalated? It also had some automated modeling components built in. This is my favorite book, by the way, the history of PKNCA from 2015 to 2025. The next part is, when I became a consultant, I wanted it on my own. I wanted what I had at Pfizer to be able to use as a consultant, because it was really useful to me. And so in 2015, I had the first release of PKNCA on CRAN, and following that, I over the next approximately 5 years, it excuse me, it was stably growing. It had continued to evolve and build with extra features to help with different dosing routes, to help with other components that were helpful to improve reporting features. And in the last 5 years, it's started to accelerate with more external collaborations. Ruminate and ANCA are two graphical interfaces for PKNCA, so Shiny apps that have slightly different focuses on how they're looking at the data. And they've really helped enable people who are not as ready to do the coding side to use PKNCA themselves. And just for clarity, both of these, part of the benefit of open source, both of these just sprung up and started using PKNCA. I didn't know about either of these until more than a year after they started. And that's another one of the benefits of open source, that they're there and people can use them. And I started getting questions from people who I didn't know, which is a wonderful part as well, getting to network broadly to people all over. And then I realized, oh, they're asking all of these questions because they're writing these packages. More recently, the Gates Foundation has helped fund some efforts to help PKNCA integrate better with regulatory approvals, especially for generic approvals here in Africa. And so that's been another big benefit that we've been able to take forward. And what are the goals of PKNCA, and where is it going? From the very beginning, PKNCA has had a desire to give accurate answers forever. The entire design has been around make reasonable suggestions based on your data, always leaving the person who is doing the analysis to really to make the decisions. And if there's uncertainty, or if there is any sort of problem, PKNCA does several layers of data checking for you, so that you are aware of issues in your data. It will let you know if you have a concentration above the limit of quantification before the first dose. It will let you know about if you have two measurements that are at the same time point, and so you probably have some sort of data management issue. Another thing that it does, and this is one of the other advantages for being open source, is it has complete validation. It has greater than 99% code coverage, which means that more than 99 out of 100 lines of the lines of code in the data in the package have a test that verifies that it works the way it's intended to. And that's a difficult thing to achieve, but it's worth it, because going back to the concept of all software having bugs, I'm doing my best to make sure that PKNCA doesn't. And importantly, it helps track if I accidentally change something in one part, that it doesn't have an impact on something that shouldn't change in an unanticipated way. And the next major part is that the additional integrations to support graphical interfaces and more. Where is the future going on bioequivalence and pharmacometrics? So I want to start out with closed source solutions work. So this is not, again, to throw any one target under the bus, but to me, they are less simple to use. And like I said at the beginning, I find bugs in every software I've worked with. If I find a bug in an open source package, 9 times out of 10, I'll say, hey, I found it. I'll put a post on GitHub, say, hey, I found this issue. This is where in the code I think it is, and this is a fix I think might make it work. Closed source, there are some things that have never been fixed with more than a decade of waiting. Integrations work much more easily with open source, as I mentioned, that you can use PKNCA to initialize a population PK model using the Babel mixer package. You can write all of your equations for your population PK model, and this is going a little bit afield of PKNCA, but you can write all of the equations using the NL-Mixer2 extra package. I don't know if you're like me, but I have on a time or two made an error transcribing my non-mem model into a report. Well, this can do it automatically. Speaking of non-mem, you can actually import non-mem into NL-Mixer and R using the non-mem2RX package and use it with all of the tools that NL-Mixer has. And you're forever able to have a fully validated, qualified computational environment. With closed source packages, you can't necessarily, if you need to rerun something that was on something where you have a time limited license for 10 years ago, that software is no longer available because it doesn't exist anymore. You can't necessarily get there. So with that, thank you very much. And
thank you very much for that very insightful talk. We'll take a few questions.
maybe if you want to say the question, I can repeat it.
Vashni, do we have any questions online?
Yes, we do. A very interesting one for Bill. So firstly, Bill, I really feel bad that I'm missing out on a sticker. So if you could send one back to South Africa, give it to one of my Stellenbosch colleagues in the room. It'll be great.
Definitely will.
Bill, your comment on all software have bugs have created quite the chat virtually. And one of the questions is, like we do know that we have some beneficial side effects with drugs. Do bugs also have some favorable side effects?
Ooh. Well, I've gotten estimates that have been wrong in the direction that I wish they actually went, which is not actually a yes to that question. The only time I can think of that I've seen a bug have a beneficial side effect is where there was interaction between several pieces of software and the bug was actually being used by subsequent software to work in the preferred way. But in my opinion, that was such a niche case. I will say effectively no. I can't think of a time that a bug has been positive. Maybe there is something, but it's not something I've experienced.
Great, thanks, Bill. Over to you, Phumla and Natalie, for questions in the room.
I have two questions. Can you hear me? I have two questions. And the one is there are different types of bioequivalence concepts, like the standard one, and there's individual bioequivalence and maybe others. And also there's difference in the concept between bioequivalence and relative bioavailability. And does your program cover all these different aspects? And question two is more food for thought for the future. Do you think that these programs might also be used by regulators when they check the data that have been submitted, like African regulators in the future, who then also will need to be trained on these systems?
Sure, both good questions. I'll start with the simpler, which is the second question. And I know for a fact that many regulators throughout the world are using PKNCA. So that to me is not the future, that is today. And I know that because they ask me questions, they tell me at conferences and otherwise. So from that perspective, I think it is simple and straightforward, yes. For the first question, and for African regulators, and I'll generalize it to anyone who isn't familiar with PKNCA. There are training materials readily available online. I do less often than I wish I did training sessions that are live or online, and so hopefully those can get people going faster. Also, I'm readily available for questions, especially by GitHub, so that everyone can benefit when the question has an answer. For the question on how the different concepts of bioavailability are handled, in my opinion, relative bioavailability and bioequivalence are different interpretations of a similar concept. And so from that perspective, I would say, yes, they do. It can do any of those types of analyses, and the replicate BE package can definitely do many different mean bioavailability evaluations. For individual bioavailability, I'd have to double check. I'm not sure that one off the top of my head.
Hello. First of all, I want to appreciate for the continuing training, because I've attended multiple trainings on PKNCA. So my question is, it has one limitation on sample size. When you're looking at maybe AUC, so you have to look for another package to get the answer. So what are the, how many points do you need to get the calculations for some of those parameters? Because sometimes it gives you the message, the sample size is not enough, so you have to look for another package. So what's the maximum number of sample size?
So there are a few different answers to that. And this is more of a general question on non-compartmental analysis, where the number of samples that you need for any different parameter, it's a bit of a question of, I like to say, how long is a piece of string? More is better, and you can keep getting, and the more you have, the more precise your estimate will usually be. Most people will say that the minimum required to calculate, for instance, an area under the curve is 3 points that are above the limit of quantification, but that also really depends on the precision that you need from the calculation itself. And it also that's a business rule that many companies or institutions require based on their own requirements for reporting. For half-life, you need at least 3 points to estimate the half-life for an individual. And that's just because any 2 points can make a line, and you need to have something where you're really estimating something. Technically, you can do it with 2 points, but you have to be really confident with that those 2 points are actually reasonable to give you the estimate. And that's good. As far as I'm aware, those should be true across any software that you're using, as long as it's doing non-compartmental analysis. If you go into a modeling framework, you're in a very different analytical space, and so it won't apply the same way. And then beyond that, I would say the other major parameter that people are often looking toward is Cmax. And for that, it's not necessarily a number of points, it's having a concentration measurement at the right time that's in a reasonable time to be around the time of maximum concentration.
Thank you, Bill. I'll take liberties as the co-chair to ask another question. As a non-modeler, do you think the reporting tools can use augmented intelligence to write reports that can be understood by clinicians?
Definitely. So for any sort of reporting, I mean, I think that's a very sweet spot for augmented, or the more common term of artificial intelligence. Yes. But I do like that as a pivot. And what I think is really key about this is the analyses that PKNCA is doing by itself and then carrying it forward can be a very straightforward input to build some automated reporting that can either be heuristic based or with some sort of AI tool. And those reports can readily be tailored toward the audience. So you can easily imagine the report being, please give a summary that give a detailed summary that will be for a pharmacokineticist or a clinical pharmacologist, and also please give a clinician-focused summary that can say the peak concentration is at 2.5 hours, etc., like we saw earlier.
Yes, I have a short one. Thanks, Bill. Can you speak more about the efforts you're working on engaging the different regulatory agencies in Africa? What exactly are you interacting on with them? It is something that we've been curious about within Uganda, how to engage our National Drugs Authority, which is our regulatory agency. What exactly are you doing with PKNCA?
So
Bill, can I, sorry, I'm jumping in, but you've now used to me in this room. Since that's a regulatory question, why don't we go to our regulatory speaker and then we take that question again during the Q&A time for Mahlodi's talk. What do you think?
Sounds fair.
Thanks. Back to you, Phumla.
I also agree. Can you also keep your question for maybe later? Thank you. Thank you, Bill.
Thank you very much.
Our next speaker is Mahlodi Maropa. She is a manager of clinical pre-registration evaluations at SAPRA, the South African Health Products Regulatory Authority, with nearly 18 years of regulatory expertise. She has led teams in clinical evaluations, operations and compliance, streamlining processes and fostering collaboration. She's known for her adaptability, results-driven leadership, and she has consistently advanced efficiency and excellence in regulatory practice. Over to you, Mahlodi, and she'll be talking about leveraging AI and large language models for BABE dossier analysis.
Okay. Thank you, everyone. I think most of the things that I wanted to say, the former speakers has already said them. So this is gonna make my life easier as we're gonna be engaging on this. As Bill has indicated, that there's a need for us to move as regulators, because the work that we do is very tedious. And as you know, that the dossiers that we receive, and we did say that 95% of the dossiers that we're receiving are generics. And those generics, they've got bioequivalence data in them. And I must say that it takes a lot of time for us to review that data. So also, I've learned a new word from Steve today, to say AI. Now we need to use it as automated intelligence. So with that said, it says what AI can do for regulators. We need to enhance efficiency, because we as regulators, especially in Africa, we've got a lot of backlogs. So we look at ways that we're going to reduce our workload and make access to medicines faster. So there is a need for us to go into that space. We need AI to improve decision-making and compliance. We heard from Bill that he's talking about the consistency of these tools that they are coming for us to use as regulators. But we need to know how we use them. And then also we need to make sure that we mitigate any risks that will come with those AIs. So we need to detect patterns, and it needs to support evidence-based decisions that we're having. And with that, we need to have an elevated engagement and satisfaction, both from the applicant side and the public side. Because once we do all these things, the three apartheid, which is the regulator, the applicant, and the patient, we will all benefit from the use of AI. So as we were doing our research as SAPRA, is that we saw that there's actually there's a significant value in this 3 dimension, which is efficiency. It's one of them. Doing the same thing faster and with less effort. So we've already spoke about that, and optimizing opportunity cost. This is very important because the time that we're going to gain in reviewing, you will see one of the slides, I'm actually showing how long it takes for us just to review BE data and actually for one API. You would see in some cases for FDCs, you get 4 BE studies if it's 2 APIs. What more if it's 3 APIs? So it's 6. Because some we need to submit fast in a BE in a fast condition and in the fed condition. So we need to review those ones as well. So it actually takes a lot of time, hence we're speaking and we're embracing the issue of efficiency and the opportunity cost. AI will allow us to do data management and knowledge management, in that whatever information that's going to be in that AI with the next API, the next application that you're going to receive, there will already be information that you can actually do reliance on it. Quality, we've already spoken about it. The most important thing is the language library that this AI is coming up with, because it's going to be storing information that we'll be getting. So then issues of accuracy of information and consistency is coming back again. And the tools that we're using, they must be able to do what we want them to do. And we want to do data automation and data analysis. So this is what we want the AI to assist us on. I think we spoke about the bioequivalence studies that we're receiving, and we all know that these are important because these are the fundamental studies for us to ensure that the generics products that we're having in our markets are safe and efficacious. So in South Africa, this is the process for us to do a dossier assessment. We receive a dossier and it gets split into 4 units. We know that other regulatory authorities, they will have one person who's reviewing everything. So in South Africa, in SAPRA, what we have the Clinical Pre-Registration Evaluation Unit. This unit will evaluate the BE and the labeling. And we have the Pharmaceutical Pre-Registration Evaluation Unit that will evaluate the quality aspect of the dossier. And we have the naming and the scheduling unit. This unit, it's where you would just apply for your name of your product. And then also the scheduling is very critical because we are mandated by the Act that each product must have its schedule, because there's an implication with those products that we're registering in terms of access to the patient. Some they're prescriptions and some they're available on the market. So, and then inspectors, they would then do our GMP assessment. So in terms of our annual performance plan, we as SAPRA, we've committed that we want to take 250 working days for us to prove that one product. So this is the time with the regulator. So this is what we are aspiring to achieve so that we make access to medicine to go faster. But this can only happen if we put mechanisms in place that is going to assist us to reach those goals. So what I have is when a dossier comes in, screening happens. So the screening is done by both administrative support and technical support. these are our scientists and pharmacists, because there's an element of assessment with our technical screening. There's a template that we use because we want the dossiers, before they move into evaluation, the correct information is available and it's in an acceptable format. So hence we're using, and you can see the review timeline for one dossier. It takes about 3 to 4 hours. So AI will help us in bringing in the efficiencies when we employ that part. So once the product has been approved, then it will move into the initial screening. So with the initial screening, for the BE, we're using a WHO BTIF form. So that's a bioequivalence trial information template, which is populated by the applicant. It's basically the summary of the BE. However, in most cases, we find that the applicants don't populate it correctly. And we have to now go back into that whole BE dossiers. And we all have to go into those studies that applicants are reviewing. Hence, as you will see that the review timeline moves from 7 days to 20 working days for you to complete that. So there is a need for us to employ whatever automation that's available for us that we can do. And that same API, same report, it has to move into peer review. The peer reviewer takes between 3 days to 7 days for them to complete the evaluation. Thereafter, then we will have what we will call a QA review that is done by our expert assessors. That is 1 day to 2 days for them to complete, depending on the complexity of the product that they're reviewing, depending on, like I've indicated, that you may find that it's an FDC product. So you need to now go and consolidate everything. So once you're done, then that's when you will go into your labeling. I think once you've done reviewing the BE, then that's when you can start reviewing your labeling, which is your package insert and the patient information leaflet. So then queries will be raised, it will go to the applicant. So now the response stage, it's much faster because in most cases, if we recommending registration and we try by all means that our screening site is as tight and robust in such a way that we don't accept substandard dossiers into the system. Hence, we want to meet that 250 working days. So our response timelines, they're very short because in most cases, it's just addition of information that we would require. And then in a case where we have all those 4 units have approved, then it can move into finalization. Finalization can mean registration, can mean rejection. So that's the process that we employing. Hence, we're saying based on this. So as SAPRA, we now have moved into saying, what can we do? How can we use AI? These are currently AI tools that are under development. So the pharmaceutical analytical triage tool, this is where we're seeing, we're using it. We want to see whether can we have a tool that is going to triage applications for us, that these are low risk and these are high risk. Which ones can we do and which ones we can leverage on? And which ones have been approved by other RRAs that we can also do reliance on them. So this is what the tool is going to do. We have the GMP screening and the primary review report. That's also under development. I did mention the issue that there's a technical screening tool for market authorization that we also is under development. Hence, that will assist us with the first phase of evaluation. And in the first phase of evaluation, this is critical for bioequivalence because in some cases you find that an API, a dossier has been submitted and the applicant has done only a FET study. They did not do fasting and it's required. So should be rejected screening. Because for you to go do another trial, we can't wait for you because we're meeting our timelines of 20 working days. 250 days. So we have to reject and say you will only come in once you've got all the requirements. So this tool is very important for us as for evaluation, so that if we can perfect this, so when we go into the AI, as Bill has indicated, then now that's when the evaluation of the dossier is coming. So this is our vision and mission for digitalization and AI, that we're embracing it and we want to be in the forefront in making sure that we're adopting digitalization and AI technologies to elevate regulatory outcomes and enhance public delivery, because our main mandate is to make access to medicines. So to mitigate that is that adopting AI, Stephen spoke about automated intelligence that regulatory processes and operation and reduce operational inefficiencies. So this is what we need to do so that we can meet our this mandate. This is going to be a phased implementation with flexible and scalable structures. As we're doing lessons learned with what we're doing with our technical screening tool, they've built it and we've tested it and then we gave them feedback. They're going back to correct and say, these are the more things that we still want to do. These are the things that we think we've left out. And as you work with the developers, you then realize to say, oh, actually, we can add more things into the system. So it is important that as we develop these AI tools, we collaborate with our developers, and at each and every stage we are available, and you've got people to test it, because you don't want to find that you've got a system, but it's not user-friendly for you. So we need to make strategic and systematic build into the enabling environment is very important, and integrate across the system. That's why we said we started with the screening, but with the intention that when we go into evaluation, it's a build-up format. And there's a lot of change management that needs to be done, especially for the regulators, for people that are used to evaluating and having trust on the system and AI to say, should I double check? Did it do it right? So there has to be a change management that we need to bring on board, and in-depth support to be provided. This could be in a form of trainings. This could be actually in a lot of things, because we need to harness the fact that AI is here and we need to be part of it. We can't wait for others to do the AI and then we come at the end, because you're going to be left alone. Actually, we were surprised to find that there's actually many agencies in Africa that are actually doing AI tools in various forms. We must make sure that we comply with the privacy, security, ethical, and regulatory standards in the AI, because it's important that we protect the dossiers that we're getting from applicants. So the benefits for employing digitalization, automation, AI is to reduce time so that we can increase efficiencies. Enable reviewers to spend and engage on technical content. Our reviewers are actually, they've got fatigue on the administrative things that has to do with the dossier. If those ones, they can be auto-populated by the system, and then we engage directly with the dossier, the timelines that I spoke about, they will be reduced drastically. Because by the time the assessors, they get to review the actual data, they spend a lot of time doing administrative work, populating the template, verifying information. So if AI can be employed, this will assist us and it will contribute to our work-life balance. Because now, by the time you do actually your work, you're really exhausted. So because of the stretched timelines that we're having and the high backlogs, this AI will really assist us in the regulatory fields. And it will provide opportunity to work with innovative tools and build new capabilities, because we don't know what AI has for the regulators. I think currently now many regulators, we are trying to see what can we do with AI. So we do have a lot of use cases in our regulator that we have identified that we can use for the AI. Some of it is we find out that other regulatory authorities, they're actually using AI to draft SOPs for them. Now we're using assessors to do SOPs. So they can draft and then and assessors, they can actually come and confirm or verify. So those are the type of administrative work that I was talking about, to say AI is here for us, let's use it. It can actually search documents for you. So we're seeing that the bigger regulatory authorities, these are the things that they're doing. And I know in some of the African continents, some of the African countries, we have issues with counterfeit. And one of the countries, they are actually exploring the sound-alike and look-alike tool that is able to assist us to identify products that are going to be available, that are registered by their own authority, so that we are able to see, because there is a lot of errors. And when we see the doctor's prescriptions, it looks like and it sounds like, especially getting a call from a doctor to say, please give a patient this. Sound alike, look alike. We want to see how that's going to help us and make sure that we don't have products that have this sound the same on the market and look alike on the market. I think this is my last slide, just to show that AI has been explored by many regulatory authorities. Thank you.
Mahlodi, you know, this is my favorite collaboration, you know, collaborating with the regulators, because I think that's where we can bring the biggest impact.
Yeah.
I'm just pausing while so to the chairs, Natalie and Phumla, we have a time constraint because someone needs to go to prayer, and we therefore would prefer not to take a question now. Mahlodi, if you allow us, and then we can have Mahmoud come up and do his presentation.
So our next speaker is Mahmoud Ali Afifi. He's an associate scientist in pharmacometrics at CETARA, supporting model-informed drug development and regulatory submission. He is a clinical pharmacist by training. He holds master's degrees in health informatics and applied statistics and econometrics, and is a former Pharmacometrics Africa Fellow. He has over a decade of experience as a clinical researcher and biostatistician, supporting clinical trials and observational studies in clinical data analytics and real-world evidence with a focus on model-based approaches in drug development and biosimilars. So welcome, Mahmoud.
Okay. Good morning, everyone. Thanks for the organizing team for this kind invitation and this kind introduction. My name is Mahmoud Ali. I'm an associate scientist at CETARA, and I was the ABT fellow in the ABT program in 2022. And my mentor was Samuel Muksasi, and he was my mentor in this project. And many of you keep asking, I'm living in Africa, and how I can apply the pharmacometrics while we don't have a real drug development from scratch. 90% of drug development, it's 95% it's generic drug development. So I think this presentation you will enjoy it. I hope that. From the title, it's about the bioequivalence assessment. As you know, that the gold standard for the bioequivalence assessment, okay, the gold the gold standard for the bioequivalence assessment is the non-compartmental analysis. So all regulatory affairs across the world requires the primary source for the bioequivalence assessment is non-compartmental analysis. When we talk about new methodology, so there is a limitation in the traditional methodology. As you know, that this drawbacks, all of them are related to the assumptions of non-compartmental analysis. So one of the assumptions for non-compartmental analysis, it assumes the PK linearity of the PK profile. So the nonlinear, the drugs with nonlinear elimination. You hear me? Thank you. So the drugs with nonlinear elimination or TMDD profiles, they will violate this assumption, and then all PK parameter estimates will be biased. This is the first assumption. The second assumption, it assumes, the second assumption, it assumes that you will capture enough samples in the late stage of the elimination in the terminals, in the terminal feeds. So it can estimate the clearance very well. So the drugs with long half-life, where the trials will stop early, it also will violate this assumption. The third assumption, it assumes also that the variability across all subjects for the PK parameter estimates, there is consistency in them, there is homogeneity in them. So the drugs with high between subject variability will also violate this assumption. So as you see, all of these limitations exist in all countries across the world, but also in Africa, we have more limitations related to the resources. So we always keep trying to keep the trial cost very low by reducing the trial duration and reducing the number of subjects and number of samples. Okay. So this presentation will go over four stages. The first stage, we will cover the overview about simulation-based power calculation. Do you hear me? Is it working? Okay, thank you. So we will go over four stages. We will take you from non-modular stage, because I know some of you here are pharmacologists and from non-pharmacometric background. So we will cover about something called simulation-based power calculation. Then we will give a glimpse about the software and the programming tools that we used in this complex methodology and how we explore different scenarios. Also, we will cover two complex PK profiles, how we implemented the model based bioequivalence on them. Then we will see what is the regulatory vision and what is their opinion in their methodology. So, in the clinical settings, when we have a problem, what we are doing, that we put a hypothesis that a new approach is better than the current approach. Then we formalize that in terms of clinical question or research question about certain population with strict inclusion and exclusion criteria. Then we design a trial, run a trial, then we get the data, and this data will be summarized and interpreted to answer the first question and the initial hypothesis. This is the traditional approach that in clinical trials and everywhere. But there is another approach called the modeling approach, or in silico modeling simulation trials, where we fit this data with a mathematical model that can understand this population very well and can explain the variability across all subjects very well. Then this model will answer multiple questions instead of one question in real studies by designing many scenarios, many designs in the same population. Then we execute these trials. Also, we get data and we interpret this data to support the decision-making process in the drug development. But take care you need to get enough power for each trial to avoid the misleading decision in this kind of trials. So many factors actually affect the power. In the core of them is the trial design. Also, many factors in the trial design affect the power. As the sample size increase, the power is increasing. As the effect size increase, also the power is increasing. Even the design of the trial, is it crossover? Is it parallel? it also will affect the trial. Also the type, the error type, you know that the power in statistics is 1 minus beta. So as the beta increase, the type 2 error increase, also the power decrease. So in the core of them, in the core of all of these parameters is the sample size. And we mean in statistics by sample size, the number of subjects, the number of samples, the number of arms, all of this affecting the power. So there is a term in statistics called simulation-based sample size determination. So you keep adjusting the sample size until you reach to certain level of power, and keep doing that until you achieve certain level of success and certain level of power to test your hypothesis and test your scenarios. To summarize that, we will assume we have a model, we design very simple scenario, then we test the hypothesis for this scenario, and to avoid the selection bias or any bias, we make many replicates, then we calculate the power for this scenario. But you need to also test many scenarios, so because maybe other scenarios will have a higher power this scenario. So we will repeat the process for other scenarios, say X scenarios, and compute the power for each one of them, and plot the power curve. And as you plot this power curve, you will find new gaps, new ideas, and that means new scenarios, and you keep doing this process until you reach your target of a power. This is the simple idea for in silico simulation studies that could replace the traditional approach that we use in NCA. So let's back to our question. As we mentioned that NCA has many drawbacks. Our question now, can we use this model-based approach to replace the NCA when NCA is unapplicable? Can we simplify the number of subjects, the number of samples, and the trial cost and the duration of study? Can we use this in PK complex profiles like in TMDD drugs, like high variable drugs, like drugs with long half-life? Actually, many of African diseases, very complex diseases, we have this kind of profiles. We have nonlinear PK profile because most of them are biological drugs. So it's very important for us as African countries. And this is the question that we try to answer in EBT program with my colleagues. As I mentioned, we start with the model. And here is the model. It's trastuzumab drug. As you see here on the left, this is the published PK profile, and we reproduced it using RxOD on the right. As you see, it's very complex profile where we have mixed elimination and 3 compartments. And as you see on the x-axis, we have very long half-life. So it combines the 2 situations where we have non-linearity and also the drugs with long half-life. And we will see how the NCA will behave with this drug and how the model base will behave with them. As we mentioned, after we make a model, then we start to set a lot of scenarios to test all of scenarios to build the power curve. And we explored many designs and many scenarios based on 4 parameters. The first parameter is relative bioavailability. The second one is sample size. The third one is sampling strategy. And then the model specification. So we tested many FRELs, bioequivalent FRELs like 0.05, 0.1, 1.1, and also non-bioequivalent FRELs like 1.25. It's non-bioequivalent. And also we tested many sample size until we reached to the power 90%. So you keep investigating the power as you keep simulating new scenarios. So how you choose which sample size to simulate based on the power curve. And also we simulate many sampling strategies, rich, moderate, sparse, after using optimal sampling design. This is a technique, statistical technique that use facial information metrics to tell you what is the best sampling time points that will give you the most precise PK parameter estimates, that will give you the estimates with the lowest relative standard error. So this technique will tell you at which time you will pick this sample. So here for each design we have 12 samples. For moderate design we have 8, and for sparse design we have 4 per each group. 4 per each group at different time points, and also you will see how each modality will work with them. Also, we need to test the robustness of our methodology. What if as a modeler, you fit with the wrong model? So we will make misspecification in the compartments. For example, instead of 3 compartments, we will use 2 compartments. we will increase the specification. Instead of 2 compartments was mixed, we will make it non-linear elimination only, and we will see the consequences on that for the bioequivalence assessment. So it's working now. Okay. So the big picture of our methodology that starts with in the literature. Any model, and using the RSPXNME, we simulate very big database, 1,000 subjects per each formulation with extensive sampling. Then, as we mentioned, we started to make scenarios. Scenarios, how to make subsetting for them. So we will make subsetting based on 3 parameters: the sampling design, the FL, and number of subjects. But we cannot make just filter sampling directly because this will make selection bias. So we need to make random sampling with random sampling with replacement. So this is the concept of bootstrapping. You make sampling with replacement, for example, 40 subjects, and this is the big database, all of this population. Then we start to make random sample for each one of them, and each run has each subject has the same probability to be chosen in every sampling run. This is the concept behind bootstrap. Then we have one data set now. As I mentioned, we need to make, for example, 500 replicates to calculate the bar at the end. So we will repeat this process many times, 500 times. And then we will make parallelized fitting by both PKNCA package to calculate to use the NCA modality, and also RSPXNME to use the model-based bioequivalence. Then we make bioequivalence assessment using the TOS test. Then we calculate the power at the end. What is the meaning of the power? How many replicates of all of these replicates who achieved the bioequivalence? As you see here, some has right, some has wrong. So how many of them who achieve the bioequivalence? This is the definition of power. And as you see here, this red line, which is our target. So we keep adjusting the number of subjects until we reach our target. And we keep also testing other sampling scenarios, moderate, sparse, and also different frills, test the bioequivalence and non-bioequivalence scenarios, and so on. And also we test other method-specified models. So as you see, it's very, very big project. We ended up with 300 scenarios. Each scenario takes about 16 hours if you have a good virtual machine with 32 cores. So we needed high computation machines. Ended up with, we used 700 cores over 18 virtual machines. And as you see, the automation here is not an option. You will make a lot of errors because many models are work together. So we automated everything from the beginning. From the inputs, when the analyst run the analysis, it will make a folder with the name as analyst, as you see on the right. Then inside each folder, you will find folder for each scenario labeled very well. And there is another program will go over all of these folders and all of these scenarios and summarize it in one table and specify the name of the modeler and the path of this results, because if the modeler make something wrong, the program will capture it and will tell you these results exist in this folder, repeat it again. So this is the advantage of PKNCA, and this is the advantage of any programming tool, is that automation will be very easy, the collaboration will be very easy, where many users can work together on the same SharePoint and can see the progress of each other. Then the results. So as I mentioned, our target to see the power. This is the idea behind assessing any modality, like in MRI, for example. How to know this modality is working? You know the disease is a disease or not. Then you see the modality how it will capture it. If there is a positive, does the modality will capture it as a positive or not? This is the idea of power. So here, as I mentioned, we tested that in 2 biosimilars drug. This is a trastuzumab drug. As you see, this is the power curve. On x-axis, the number of subjects. As we move from left to right, we expect that the power will increase. And here, the sampling is rich design, and FREL 1.05, which is bioequivalent. We know, we simulated from the beginning that is bioequivalent. How these modalities will capture them. As you can see, that all models have a higher power than the non-compartmental analysis. And the non-compartmental analysis needed the double number of subjects to capture the bioequivalence in comparison with the true model. This is enriched design. What about the sparse? While the sparse true model captured the bioequivalence as the same number of subjects, but NCA was not applicable. This is enriched. This is in 1.05. What if we increase the FRL to 1.1 by decreasing the effect size? We will expect that we need more, more number of subjects. As you see, the NCE need the double, but also in true model also needs the half of them. And the same also, the sparse design, NCA is not applicable with X, so the sparse design is comparable with rich design in model-based bioequivalence. This is answering the first question for us. The second question is that all models in all scenarios and in all sampling strategies and in all FRLs, all models have a higher power than the non-compartmental analysis. But this high power is very dangerous. If the model keep always capturing the bioequivalence with a higher power, it could capture, it could say, it can conclude the bioequivalence when the drug itself is not bioequivalent. And this is a concern of all regulatory. This is the definition of alpha error. So let's simulate non-bioequivalent scenario, which is 1.25 FRL. And here the misspecified model has inflation and type 1 error. And what we know that NCA will control the type 1 error. But the surprise that also the true model also control the type 1 error, even in sparse design where the NCA was not applicable. It was not controlled in the beginning, but was increasing the sample size, the power increase, and it captured it very well. Let's make small misspecification in number of compartments. Also, the misspecified model in the number of compartments also control type 1 alpha error, except in sparse design. And here's the question: what if we take the average of all of these models? We will get a result where we also control the type 1 error. This is trastuzumab. Let's test that on another biosimilar drug like clonileximab, which has two compartments with very deep nonlinear elimination. This is the results for NCA, and this is the results for the true model. As you see, the Cmax, they are superimposed for each other, but you see there is a difference between them. Who is the most precise? Here, the NCA has a higher power. So we also plotted the truth value from the big simulated data, and we found the surprise that it's superimposed over the true model. That means that NCA was biased in this scenario. Why? Because we have here very nonlinear relationship between the AUC and the dose. We published all of these results in Beach 2023 in Spain. You can scan this QR code to get the poster. And we also make tutorial on Certara R-Scroll Lesson 9 for all scripts for model-based bioequivalence, line by line explaining it in very clear way for even number grammars. Let's see the regulatory vision. Here, the statistical approach for bioequivalence for FDA, the draft guidance, they encourage the use of model-based bioequivalence. And the sparse sampling section, they mentioned that they consider they can control the type 1 alpha error. That model-based can control the type 1 alpha error, as we mentioned in our results. And while the European agency, they didn't mention that in their regulatory PDF, but I sent them email and they mentioned that they encourage to use model-based bioequivalence when NCA is not applicable, but they don't use the model-based as a primary source of evidence for that, but they encourage to use it if NCA is not applicable. What is next for us to test this on other biosimilars and explore the model averaging technique to control type 1 alpha error? So the conclusion, as we mentioned, that model-based bioequivalence can be used instead of NCA when it's not applicable, and it has a good performance to decrease the number of subjects and number of samples. I would like here to acknowledge my colleagues in EBT, Watson and Vera, who worked with me on this project, and our mentors, Samir, Colin, and Ernie, who choose this project. From 3 years, this project, no one know about model-based bioequivalence, but now it's one of the most hot topics in FDA office. And thanks for the Ministry of Higher Education and Scientific Research who provided us high computation machines. Thank you so much. Questions?
Phumla and Natalie, we're going to give it to you to take over in a minute. Mahmoud, apologies that we scheduled your presentation so close to Friday prayer. So
no worries.
We'll excuse you if you need to rush off.
No problem. Can take some question.
But if you can take a question, then I give it to Natalie and Phumla.
Thank you, Mahmoud. That was a wonderful, wonderful presentation. We'll take a few questions. Let's start here.
Yeah, I have two quick questions. One, for your model-based, assessment, I'm not very sure of what this hypothesis is. For the NCA, of course, we know that is probably based on AUC, but for the model-based, I'm not sure how that is, set up, because obviously, they're going to be different if you're looking for, assessment of your powers you are looking at, as the way you've described it. And also, when you talk about the optimal design, the way you use optimal design, that optimal sampling times is not optimal for NCA analysis. It's optimal for model-based, but not optimal for NCA. So therefore, it's not surprising that you see difference in power, because that is optimal for parameters that is model-based, but not optimal for AUC. So just a quick comment there.
And the first question you were asking how we derived the PK parameters for model, right?
What the hypothesis is for the model-based?
Yeah.
So, yeah, the first one was the setup of the hypothesis for the model-based, analysis compared to the NCA, because I think, you have to be comparing like with like when you are looking at power, and that way allow us to be able to see, where the difference is coming from. And the second one is about the optimal times.
So in how we derive the PK parameters in model, we know that the infusion, for example, will finish after 2 hours. So this is the Cmax, for example. And the AUC, which is the last point we take from 0 to the last point in the profile curve by integration over all the concentration time profile. This is how we derive the PK parameters in model. So each one will propose the PK parameters from its perspective. In CE, you will drive the Cmax and AUC and model the same, and then you will compare how if they captured it very well or not. Who is the more precise technique in each of them? This is number one. Concerning the optimal design, the points will cover all the curve. So even the optimal design, yes, this is for nonlinear mixed effect, but at the end, if you focus on the curve, it covers the whole features of the PK profile. So it should work very well with NCA also. Yeah, it's designed only for modeling, but yeah, the model itself, the point itself covers the whole curve, so it doesn't. I think it doesn't matter. Yeah.
Thanks, Mahmoud. Thanks for the great presentation. Perhaps it's more just a comment, and you can perhaps speak towards it based on the audience here and the need for bioequivalence, perhaps with drugs such as the antimalarials with long half-lives and the application of a model-based bioequivalence methods to analyze that sort of data. You don't have to convince me, but perhaps you can speak to the audience about the use of this, especially for the antimalarial drugs.
Yeah, exactly. FDA now recommend to use model-based bioequivalence, especially for long-acting drugs. And they made a lot of tutorials about that, especially for this purpose. Model-based bioequivalence is the first choice. Yeah, thanks, Ben. Any questions?
We do have 2 more questions in the room, but maybe we should check with Veshni if there are other questions virtually.
Hi, Phumla. So there's one question for Mahlodi, but maybe we could continue with Mahmoud's question, and then I can speak to Mahlodi's question.
Thank you very much. Mine is just, I know I cannot make a lot of sense in this pharmacometrics thing as a clinician, but you've talked about complex modeling. I don't know if you are thinking about also looking at herbal medicine trials.
Herbal medicines?
Yeah, herbal medicines. Yes, because right now I'm running one trial on Professor Ogwang's hypertensive medication, which clinically it's doing really great, but then we don't know what is behind there. Can we adopt this kind of thing?
You can apply this in any drug with complex PK profile. So it doesn't matter is it chemical drug or is it biological drug or anything. Any drug with complex PK profile, you can apply for it nonlinear mixed effect models. But NCA, there is a lot of assumptions you need to follow. And as I showed you in colonelizumab, for example, there is big non-linearity in elimination. And we all see that NC has higher power, but this power was biased. This result was biased in comparison with the reality that we already simulated. Yeah. Any questions?
Thank you for the presentation. For us in Nigeria, bioequivalence studies is one of the high priorities now, and capacity building in AI is one of the things we are focusing. So I want to know, and general comments now, in sending this pharmacometrics both to our regulatory and to us, the scientists. One of the problem challenging for bioequivalence study is cost intensive. And I'm looking at model-informed bioequivalence analysis, solving some problems like sample size, solving something like sparse sampling. But for bioequivalence studies, you need intensive sampling, and you need a long time, depending on the type of drugs that you are in for. So how are we going to sell pharmacometric to the regulators and to the scientists? That is a way to solve some of the challenges in Africa. That's just what I want to.
Perhaps we'll take one more question and then you can answer both of them. Just keep your questions concise.
Thank you, Mahmoud, for this nice presentation. Actually, it is very interesting for me because I conducted a real bioequivalence, several bioequivalence by myself in Egypt. And I have two questions. The first one, what's going with the long half-life drugs? So in Egyptian regulatory guidelines, we are like to be, in case we have a long half-life, more than 72 hours, it just you can stop the sampling at that time and go through the truncated AUC instead of full extended AUC. So just we can like to assess the bioequivalence according to the Cmax and the truncated AUC. So that's in case we have long life drugs like for azithromycin, as I remember. So I don't know why we consider that long half-life can be like a problem in order to go through modeling for the bioequivalence study. So they have another solution. So what is the feasibility of using model in case of such condition? And the second question, if it's like, yes. And the second question go to the feasibility of the model-based bioequivalence in order to figure out how far the covariate can be affect on the sample size determination for a specific drug. This is the second question.
You mean the covariates could affect the sample size calculation?
Yes, for example, for the creatine clearance, for the BMI, for the sex, so everything can be like to affect with the creatine clearance and hence can be affect on the T-half of the drug and will be affect on the outcome of the BE assessment and at the final.
In concerning the last questions, in model-based, you keep investigating different number of subjects and you keep plotting after you finish each scenario, you keep plotting the power curve. So who is guiding you is the power curve itself. Okay, this is number one. For NCA, you need to make sample size calculation. Concerning the first questions about that you make NCA on long half-life, take care that there's a guidance about this. You cannot extrapolate more than 20%, as I remember. While
Any questions for Mahlodi? I think please feel free to grab Mahmoud later and chat further. But we'll take questions for Mahlodi.
Thank you, Mahmoud. So I think we need to move on to Mahlodi.
Thank you.
Babatunde, you can contact him directly for him to answer your question.
I have a question for Mahlodi. Yes, I can proceed. I'm just curious, what's the proportion of submissions that you actually turn down? And the second question is, do you ever get into a scenario where you request for some data to be obtained locally instead of reviewing submissions from out?
With regard the applications that we return based on screening,
with regard to the applications that we would return based on the screening, I assume you asking at screening stage, eh? Not at registration. At screening, it's not a lot because I think during the week, if you were part of some of the trainings, that we do use a CTD format for application for dossiers to be submitted in CTD format. So in most cases, on average, it will be 2% of those applications that we reject at screening, but in most cases, those products they will comply. So the other issue that you raised is that in South Africa, we do have regional requirements. So not all BE studies are done in South Africa, and they will be done elsewhere. But the rule is, or in our guidelines, we say for a product to be regarded as a generic in South Africa, there must be an innovator product registered in South Africa. So in a case where there's a BE study that was not conducted in South Africa, we do accept those, provided the studies were done in reputable CROs that have been approved by agencies like FDA, EMA, and all that. However, we want you need to purchase the innovator product that is in South Africa, and you do a comparative dissolution against that reference product that they have used on the BE, so that it can confirm for us that indeed this product, it's the same innovator that have been used for the BE study. I hope I've answered your question.
That doesn't really address things like patient characteristics and the likes.
Not on the BE. Not on the BE. So that will be on when you're submitting for new chemical entities. This is where now we become strict on those ones.
Thanks. Vaishni, you've been waiting patiently online to ask your question. Over to you.
Great, thanks, Phumla. So interesting comment and question by Nada online, where says that given that AI is seen as a tool to alleviate administrative burdens as well as improve work-life balance, what specific safeguards or oversight mechanisms does SAPRA plan to implement to ensure that the efficiency doesn't inadvertently lead to a reduction in the rigorous human verification, as well as the critical thinking that's required with such high-stakes regulatory decision-making?
I think it's important to note that there will always be a human intervention. So we're not saying that when we are adopting AI, we are going to take decisions based on AI. So what we are saying is that we need to embrace AI to assist us to actually make consistent regulatory decisions on applications. There will still be a report that is going to be reviewed. There will still be, the process is not going to change, and the mandate will not change. We will still need a human intervention in these evaluations.
We'll take one last question in the room and then we'll close.
Yeah, thanks. I had a question regarding, I know your presentation, which was on AI and also its integration in regulatory processes, which is good. But my question was regarding PMX, pharmacometrics processes, because in this case, if you look at the milestone by the FDA, EMA, and other regulatory authorities in integrating pharmacometrics modeling into the regulatory processes, and how far we are behind as African countries as well. But so it's just now looking at SAPRA and also other regulatory bodies in terms of integration, how far are we? And also Colin is also here, but to look at, we're building capacity, and we have now units in Cape Town, Stellenbosch as well, Kampala, Nigeria. So all of these units are building capacity. But now what that means that we're having the expertise, but in the regulatory processes, are we aligning that before we also even look into integration of AI, things like that?
That's a nice one. We are, I think SAPRA have been supporting pharmacometrics and all that. So with the reviews that you're doing and what we're seeing that you guys are doing, I must say that the assessors that we've got in South Africa, they're not only internal assessors. We do have external assessors from various universities, which they bring in the skill set that we don't have internally, and they become our additional resources. So we do accept people with those skills to augment the type of work that we're doing.
Because you already have the mic, I'll give you the last question from Mahlodi before we close.
Yeah, thank you very much. It's a nice talk. My question is regarding the AI used for registration. I'm just wondering if you had shared any experience from other countries which have used AI for registration purpose before, that such kind of things. And second one, how are you going to go about it? Like, are you going to do some pilot work before really going into the whole thing, or just do the whole process? So yeah, what will be the process in the meantime?
Okay.
Thank you.
Yeah, I think we're trying to collaborate with other agencies that are already ahead. I think, like we said, that we should not start from de novo, but let's learn lessons learned from other RRAs. I know that FDA, they actually have started with their own BE modeling, and I think we attended one of the workshops that was available, and it was showing us how it's working and all that. But these are the lessons learned that we get from other regulatory authorities. In my presentation, I did say this is the stepwise approach. So it's not going to be something that we're going to do in the next 6 months, but we want to do it over 5 years, because as speakers has indicated, that with different products and the complexities, so it's not just a magic pill that we're going to say as SAPRA, that this is something that we're using and then it's going to work immediately. So this is our 5-year strategic plan, to say in 5 years, we must be in a space where we are now adapting and modifying, but we have the base AI tool for it.
Okay, we know when Colin pops up, it's actually time. But thank you so much to our excellent 3 speakers today, Bill, Mahlodi, and Mahmoud. You've been excellent. It's been an energetic session, and we'll close with that. Thank you.
But I do want to give a pre-warning to Mahlodi that there's a couple of questions that are coming through on the chat. People are going to come after you. There's the worry that 250 days is a long time.
I thought that.
And they want to know, what is the promise of AI to reduce that? But it's something to think about. You don't have to answer it now. We'll pick it up during the Q&A or the panel discussion. And Phumla, you've closed the session. That's wonderful. Thank you. Let me ask Veshni if she wants to say 1 or 2 things more.
Yes, so maybe just to remind everyone about the
The posters, I know it's lunch now, but if you could get through lunch and make your way through the poster station, our presenters are going to be eagerly awaiting for some good conversation.
And
Thanks,
Rachel,
Colin.
can you remind me as to whether the the delegates or people's choice, is that closed or is it still open?
Correct. That is closed about 45 minutes ago, but I could just ping. I think Linda's not on the call at the moment, but yes, it should be officially closed.
Okay, that's good. Thank you. And then let me ask our local host to make some comments here.
So I've actually been wanting to do this for like 3 days and pop up and be a little mini like Yoda. So yeah, a couple of local announcements. We're about to go into lunch, which will then merge with a poster session. So we're due back in here at 3. There's a couple of things to say. Be sensible. You've seen, those of you that have been here know what the queues can get like. I would suggest that some of you go and start looking at the posters first. You know, if the queue is long, just kind of look at the posters, then get lunch. We are not going to run out of food. We know that from previous days. And if we do run out of food, you've eaten far too much. So don't. You'll get drowsy and that will be a problem. The second thing is it's a good time to take the group photo because lunch is served downstairs. So let's go down. Let's get a group photo on the steps again, a bit like what we did the other day. Then proceed to lunch and posters, make the most of the interactions, and thank everybody for their energy. You're amazing.
And then a last message to the online delegates. Thank you very much for being here with us all this time. In a few minutes, we will close this session. You will be sent out into the lobby. Then remember to log back in at 3 o'clock South African Standard Time. That's 3 o'clock, 1500 hours. It should reflect appropriately on your calendar invitation. Thank you very
Sorry,
much.
Colin. It's
Yes.
East African time.
East African time. Okay, sorry, East African time.